Hello and welcome to the breakout session on Hodgkin lymphoma at Lymphoma Canada's 7th Annual National Patient Conference. My name is Christian Grassi, and I'm the Marketing and Social Media Coordinator here at Lymphoma Canada. It is my pleasure to welcome Dr. Anka Prika, who is here today to answer your questions during this breakout session on Hodgkin lymphoma. As a reminder to our audience members, please type your questions into the Q&A box. This is located in the middle of the black toolbar at the bottom of your Zoom screen. We will try to answer as many questions as possible over the course of this session. So to get started, the first question we have is, although surgical resection is the preferred method of diagnosis, it involves taking out a lymph node, which sounds more invasive. As a result, are there more side effects associated with this method of diagnosis in comparison to others?
So thank you for that question. So certainly the two methods that are typically used for diagnosis of lymphoma are to get a needle biopsy with kind of a bit of a thicker needle through the radiology department, which is really more for most circumstances, under local freezing when it is accessible, maybe a little bit more if deeper, and the side effects might be just some pain or recovery from that. Certainly, to take out a whole lymph node is a little bit more invasive, so may involve some stitches and a little bit more pain or recovery from that perspective. I would say, although every circumstance is different and it depends a bit on which area of the body you go for, usually with surgical resection, it is a more superficial or lymph nodes that are kind of on the or palpable through the body. So it's not an area where a surgeon would necessarily have to go very deep and cause a lot of side effects. So of course we try to minimize side effects, but with Hodgkin lymphoma, it is very important to get as much of the lymph node as possible to get the proper diagnosis. So we do try to get a surgical resection when we can. And again, the recovery shouldn't be a lot worse than the needle biopsy, but could come with a little bit more side effects.
You mentioned earlier that remission does not mean that the cancer has been cured, and following up on it is usually required. What are your tips for managing the fear of reoccurrence?
So that is a tough question, and certainly it would be, I would say, very normal after people go through treatment for Hodgkin lymphoma, where the focus is really on the acute care and getting through the symptoms and the plan. When it's at the end of it all, we say it looks like it's all gone, there's a remission, but we still have to follow closely, particularly within the first couple of years being the highest risk for recurrence. And so it can be difficult to then return to normal life and get back to activities and everything else while thinking about that. Probably, I mean, first of all, it's normal to feel that way. It's normal to still think about it and worry from that perspective. At the same time, trying to get back to some regular activities, whether it's school, work, exercise, spending time with family is very important. And certainly, there are resources that people can access either locally through their hospital or through organizations like Lymphoma Canada or in Ontario, for example. Wellspring can be an example where you can speak to a social worker or a psychologist or a psychiatrist to help with working through some of those feelings. And certainly because a lot of our patients are young adults, there are also some resources for young adults, again, helping get back to work and school, and also maybe access, social media platforms or groups that can help in supporting each other. Everyone's different and to what works for them. And again, it's trying to access different resources that might help, and always important or always very helpful to speak to your oncologist or to family doctor to try to access those and not feel like you're alone if that's the case.
So with younger patients, for example, under 25, Sometimes enlarged nodes stay and never shrink, but they don't light up in the PET scan. What are the long-term issues with this scarring, and what monitoring needs to happen?
So that's an excellent question, and I guess the good news is that for as far as we know, for the most part, there are really no long-term effects from having some larger lymph nodes or some scarred tissue for the long term. It's a little, some extra tissue that just that just is there. It's true that we do. That having a PET scan, which really tells us if those lymph nodes are active or not, is a very good measure of ruling that out. And then beyond that, it's again no long-term effects. Everyone might monitor this a little bit differently, but certainly in my practice, if at the end of treatment or after one or two images they really haven't changed in size and there's and we believe that there's scar tissue, I don't feel that there's a strong need to continue to monitor that in any way, other than the usual approach of monitoring clinically for how people feel, and if it is an area that can be palpated, if it's staying the same and not growing, it's not usually a worry. And sometimes, again, more imaging or more things like that can just add to anxiety, and we feel quite comfortable that if it is just scar tissue, it doesn't it doesn't grow back.
So what are some common side effects of treatment via brentuximab vedotin?
So rituximab vedotin is a newer, not so new anymore, a treatment that's very helpful in Hodgkin lymphoma, and it is a form of chemotherapy, but it's very targeted, where an antibody drug takes a little bit of chemotherapy straight to the cancer cell and helps kill it. The most common side effect does tend to be neuropathy, so having numbness and tingling in the fingers and toes, or going up from there, sometimes with pain. So that is something that gets monitored very closely, and dosing or treatment in general might get adjusted or stopped depending on that. So it does tend to be a cumulative effect. When combined with some chemotherapies, like in frontline with chemotherapy, can cause more blood counts than we would, low blood counts and more sort of fever and infections than typically seen. Sometimes it can cause some mild bowel effects, like having some upset tummy or maybe some skin changes, but those would be quite rare. So really the most common would be a neuropathy, and then just impact on the counts and monitoring for that.
What are some of the impacts on fertility for young women with the chem, especially for younger patients?
Yeah, so that's a very important and very and a good question. So, as you may have, as I talked about in my presentation prior to this, there are different chemotherapy regimens that we can use now for Hodgkin lymphoma. And some of them, some like escalated Biakov, for example, can have more of an impact on fertility than ABVD, for example, or AAVD, so adding brentuximab to AVD. As far as we know, ABVD/AAVD seems to be pretty similar to kind of the general population in terms of impact on fertility, or I guess putting it the other way, probably not that much. But of course, because we think about adapting therapy sometimes by intensifying a little bit, we do discuss fertility impact with, or most people do try to with our patients. What that impact is individualized, again, on how many cycles you might get of, let's say, more intensive chemotherapy. And actually, interestingly, the younger a patient is, the less, so the fertility impact goes up as people get older, as you can imagine. So the same amount of chemotherapy has a little bit less impact on an 18-year-old patient versus a 35-year-old patient, for example.
And building on that question, what are some, how does the chemo treatment cycle affect men and women differently in that regard?
In terms of fertility, you
Yes.
mean? So the impact can be a little bit different, or the percentage impact, or the might is a little bit different with, again, the more intensive regimens for men versus women might impact, for example, some sperm parameters and that part of fertility with men versus the impact on women's fertility. Some of the data we've had around this has been more looking at, again, the impact on hormonal changes and that piece. And of course, there's that part, but also we're trying to get more data and understanding of women and men that wanted to become pregnant or wanted to have a child, how many were successful versus unsuccessful. So there's probably a little bit of a difference between the two. And I guess building on that, certainly, I think it's very reasonable for everyone starting out on treatment to have a discussion with their oncologist or their healthcare provider about fertility preservation. And that is, at least in Ontario, where I practice, it is covered for women to have an IVF type cycle if they're going to have chemotherapy. For men, it's usually sperm banking, which has a little bit of a cost with it, but can happen a little bit quicker. Over a couple of days, versus for women, fertility preservation can take 2 to 3 weeks. And sometimes we're in a scenario where we just don't have the time to do so. Or there are some clinical scenarios where it's not necessarily safe to do so through the gynecologist, but I certainly think everyone should be offered a discussion and an opportunity to have that evaluated before going forward.
If a patient were to get radiation therapy, what are the long-term side effects that one might experience going down this road?
So radiation therapy is interesting. We've used it a lot in Hodgkin lymphoma, and it works very well. If you, I think I tried to briefly highlight that in the talk as well. If certainly in descriptions of treatments for Hodgkin lymphoma over the decades, toxicity from radiation has been highlighted. So, and most commonly, the shorter term effects tend to be more localized to the area that's being radiated. Some might have some inflammation, redness around the skin. If it's around the lungs, for example, might have a bit of a cough or inflammation for a little bit of time. But yes, we worry a little bit more about potential long-term effects. And that again depends on what part of the body is being radiated. The one that most often could happen is in the chest area, and the 3 parts are, so if there's how much radiation there is to the heart, and that can have some long-term effects in terms of risk of having heart disease and blocked arteries and things like that. In particularly women, there's a risk of cancer. That can be a risk of, or that was one of the concerns over the years of getting things like breast cancer, or also having impact on the lungs, getting other cancers. That being said, radiation techniques have improved dramatically over the years. And now it's much more targeted and localized to the areas that need to be radiated. Some more recent data suggests that the risk of breast cancer, for example, is not that much different than the general population when looking at application of radiation for Hodgkin lymphoma. And similarly, again, because we have different treatment options, including chemotherapy regimens, when it comes to the heart, we often will look at where the lymphoma is, what the location is compared to the heart, what the heart dose will be. So that's something radiation doctors calculate and make a risk-benefit decision about whether how much the radiation piece could add to the disease control long-term versus the potential side effects. But I guess just want to reaffirm or re-say that a lot of the side effects of radiation that have been of concern over the years have gone away with just the advent of much more modern techniques.
Thank you for that. Before we continue with more questions, we've had some more of us join. So I'd just like to remind everyone that at the bottom of your screens, you'll see the Q&A button down there. And you could use that button to type in a question. And as we're working through them, we'll see if we can answer as much as we can. So the next one we have here is if a patient passes the 5-year mark, what is the likelihood of the Hodgkin's lymphoma coming back? And what is the likelihood of other cancers coming?
Yeah, so that's a very good question. So um, certainly the 5-year mark in a lot of lymphoma, including Hodgkin lymphoma, is a very significant landmark. And we would probably say after 5 years, the chance of it coming back is pretty much 0%. That being said, it's there's always there can always be a very small chance in some people, but that risk is really very low, and it would be quite unusual. When we look at some different regimens, chemotherapy regimens, and risk of other cancers, it's probably in the few percentage range, maybe 3-4%. Some of that is can be solid tumor cancers, and again, depending on what treatments were had and age of patients as well. So of course, older patients are more likely to might have an increased risk of other common cancers through that. And there's a small chance, maybe 1.5% of getting other blood cancers. So a few percentages, which is probably a little bit higher than what the general population, all of us, might have as a risk through our lives. But the risk of Hodgkin lymphoma, we think of essentially 0 after 5 years.
Yeah, and as you said, just to clarify, that risk is is lower for younger people as that goes, correct?
That's right. That's right.
Another one we have here. Can you expand on the toxicities associated with treatment via escalated BIACOP? We're having some internet connection issues right now. My apologies, everyone. We'll see if we can bring back Dr. Anka Prika as fast as we can. Just bear with us for a moment. In the meantime, if anyone has any other questions, it'd be a good time, just to, build up those questions, and we'll see how far we can go as we continue.
I'm so sorry. I'm not sure what happened. I think it kicked me out there.
No worries. Okay, so we're back. Everything's good proceeding as normal. We're all good. So where we left off, just to refresh, I'm not sure how much of your answer even got included there, but the question was, can you expand on the toxicities associated with treatment via escalated BIACOP?
Yes, so I think I had started to describe the two different regimens, but perhaps I'll just focus on, so escalated BIACOP is a more intensive recipe that has some, or there's some support that it might get rid of the lymphoma a little bit better, but comes at some excess toxicity. In the short term, that tends to be mostly impact on the blood counts, where more people than more patients than with ABVG might need transfusions, have a risk of more infections, having low platelets and more fatigue. There's quite a bit more steroid medication given with it, so there can be rarer side effects of having issues with the bones, for example, in the short term from them. So a little bit of a more intensive regimen that for those, when we treat blood cancers, I'm not unfamiliar with it from other cancers we treat, so we're comfortable with it, but can be a little bit more impactful that way. In the longer term, some people, or there have been some potential concerns that there could be a little bit more risk of other cancers, going back to the question that was asked before. Overall, when looking at, so in Germany, they've used this regimen in thousands of patients, and it's not really convincing that that risk is really that much higher, especially that over the years, they've adapted their studies and how we give the regimen, that we give less cycles than before. And also there is a bit more of an impact on fertility than with ABVD. So those are the things to keep in mind, and the things we counsel patients about when we discuss regimens and options.
Building on that question, why isn't that treatment option more of a standard option here in North America as it is, as you said, in Germany?
Right. So I guess some of it is I have it's probably a multifactorial answer to that. Some of it is kind of how cultures have developed over time. So different places and different jurisdictions may have developed different chemotherapy regimens and kind of stayed with them. I would say, although these regimens have been studied in many or numerous studies over the years, there seems to be a consistent improvement in what's described as progression-free survival. So the chance of getting rid of the lymphoma, not having it come back with escalated BIACOP. But there's been no kind of head-to-head clear improvement in overall survival, meaning that if the lymphoma does come back with the treatments we have now, we can still get rid of it and people live just as long. So it becomes I guess a balance of toxicity versus improvement in getting rid of the lymphoma to some extent. So I think in North America, people have stuck with kind of maybe a little bit less toxic regimens, perhaps a little bit lower or a little bit higher risk of the lymphoma coming back, but then there are effective treatments at that point. Versus in Germany, they've developed and used escalated BIACOP for many years and treated many patients and believe in it. Certainly, people do use this regimen even in North America, and some of it is having comfort with it. And one of the advantages is it is a little bit shorter. I like offering it to patients, especially young patients who are trying to get back to their regular lives, because for a proportion of patients, or a good proportion of patients, it means 3 months of treatment versus 6 months with ABVD. So it can be quite attractive even from that perspective, even if it comes at a little bit of risk of higher toxicity.
We have another question here. Can Hodgkin's lymphoma ever be considered cured?
Yes, I mean, cure means, I think we would say that cure means that you think that the risk is essentially close to zero of it coming back. So that time point of 5 years, where we really think that the likelihood of coming back is very, very low, we would call that cure. And that's a common definition for many cancers. So if that risk is, again, very close to zero beyond a particular time point, that would be considered a cure. And I certainly feel comfortable saying that about Hodgkin lymphoma.
We have time for one, maybe two more questions. So if anyone has any more questions, it'd be a great time to get them in now. We have one here. Where can I learn more about clinical trials for Hodgkin lymphoma?
Yeah, so that's there are kind of different avenues, certainly depending on where the where the care is. There may be provincial or national trials to ask about through your oncologist. Most are connected to other centers that run trials and would know what's available. There are some kind of more wider availabilities, certainly through, there's a website called clinicaltrials.gov that every trial has to be registered with through, so one can search through there. And there are organizations, lymphoma related, that also try to match patients to clinical trials, even in the US, and such. And certainly even through Lymphoma Canada, I think there could be, if one reached out, we can find out a link to get that information.
So it seems we got two minutes roughly left. One last question here, I believe, the last question for this session. It will be, what are some suggestions you have for patients who are trying to stay healthy after their treatment?
Right. So certainly getting back to, or trying to get back to some activities that were regular before is important. Of course, exercise is always, I would say, recommended or encouraged as much as possible, and whatever is doable. Sometimes it is, there can be fatigue that accumulates through treatment, and getting back to the same level of activity might feel challenging, but it can be a bit of a loop, I guess, that only by getting a bit more active again, people can feel better, eating healthy, and again, going back to activities that, whether it's school, work, hobbies, I think is important. There's lots of people wonder about particular diets or supplements or different things to do, and there's lots of research going on into that. But at least I'm not aware of very specific things to recommend yet, but we may learn over time about other things that we can do from that perspective.
Thank you so much for your answers over the course of this Q&A session. I want to thank Dr. Ankafrika for taking the time to participate in today's conference sessions, both the Q&A and her previous session. We hope that those watching today learned something new about their or their loved one's lymphoma subtype. Please tune in to the closing remarks in the auditorium, which will start in just a few minutes. So if everyone would like to head over there, thank you very much for attending with us today, and have a good rest of your night. Thank you.
Thank you so much.